Welcome to IPOPI Hard Talks. My name is Martine Pergent. I am the president of IPOPI, and it is my pleasure to co-moderate this digital event with Dr. Nizar Mahlaoui. Hello, Nizar.
Hello, Martine. I'm Dr. Mahlaoui. I'm a chairman of IPOPI Medical Advisory Panel, and I'm also very glad to co-moderate this event with you, Martine.
Thank you. First, let me take a moment to thank our sponsor, BD, for making this event possible. With IPOPI Hard Talks, we will explore the complexity of our field with the help of two experts, a presenter and a challenger, who will both bring different perspectives. The presenter will give a talk, after which the challenger will open a stimulating debate. The theme today is the role of flow cytometry screening for earlier PID diagnosis. I'm delighted to introduce our presenter today, Dr. Rita Carsetti from Italy. Dr. Carsetti, you are trained in medicine and also in obstetrics and gynecology at La Sapienza University of Rome. You did a postdoctoral training in the United States at the MD Anderson Hospital in Houston, and you followed with a second postdoc at the Max Planck Institute for Immunobiology in Freiburg, Germany. And at the Max Planck, you became responsible for the flow cytometry core facility and later worked in the departments of Michael Rett and Thomas Byrne.
Correct.
Now, it's my pleasure to introduce Dr. Condino Neto, who will engage in this discussion as the challenger today. And Antonio Condino Neto is from São Paulo, Brazil. You are a distinguished physician and immunologist with a strong academic background, holding a PhD in pharmacology and a master's in immunology. You have held significant positions at prestigious institutions, including the University of São Paulo and the State University of Campinas Medical School. Your commitment to the field of immunology is evident through your leadership roles in medical societies, such as the Latin American Society for Primary Immunodeficiency, the LASID, and you're very much committed also in the newborn screening program in Brazil.
Thank you very much, Nizar and Martine. Thank you, IPOPI. Thank you, Rita. So it's our pleasure to join this meeting and contribute for the discussion in a so vibrant topic, which is the analysis of immune cells and what we can do in terms of diagnosis and how to help our patients. So thank you for this opportunity.
Thank you, Antonio. Thank you, Rita. Welcome to both of you. How will it work? Dr. Carsetti will soon give her lecture. And after the lecture, Dr. Condino Neto will share his comments, and together they will discuss this topic. During the presentation and the discussion between our two guests, you will be able to send written questions in the question tab. So let's begin now. And Dr. Carsetti, the floor is yours.
Thank you. This is, my first slide. So first, I wanted to tell you that I am very happy to be invited to give this talk. And I also wanted to tell you that, when I came back to Rome from Germany, from the Max Planck, I became responsible for the flow cytometry and then diagnostic immunology of the Bambino Gesù Children's Hospital, which is one of the biggest children's hospitals in Europe, and is in Rome. So I had the opportunities to see many cases and to make some of these very important diagnoses. So when we think about the primary immunodeficiency, actually, when we thought before about primary immunodeficiency, we always thought of, cases correlated to a lot of infections. With time, then this concept developed, and now we also include in what we call inborn error of immunity, also alteration of the regulation of immunity, like inflammation, for example, a certain type of autoimmunity. And before we really thought that was really rare, you know, an inborn error of immunity, but in reality, if we calculate all the different types of disorders, this event is not so rare. And here you can see in this slide how the number of identified defects of immunity has been increasing with time. So in these cases, you know, in the beginning, we knew that there were some cases of immunodeficiency, but we didn't have really the genetic diagnosis, so we couldn't say what was wrong with it. And it's very important to know what is wrong, which cell is wrong, which mechanism doesn't function, and which molecule doesn't function, because that can give us opportunity to find the right treatment. Now, how do we do the diagnosis of primary immunodeficiency? So it's really collaboration all the time. And it's, you know, there is this beautiful paper published in 2021 when the diagnosis, where the diagnosis of primary immunodeficiency was described as a paradigm of a trinity, because it's always a presentation between three different expertise. So normally the first person who understand that there is a problem, okay, it's just the patient probably, but then also the doctor, the clinicians. And the clinician will go and talk to the person who works in the diagnostic laboratory, and normally flow cytometry is one of the things you use a lot. And then there is a collaboration also, and it's very important, with the genetic analysis, because as we said before, what you really want to know, you want to really know the disease, so to know what is wrong. And when you find what is wrong, you again collaborate with the lab that demonstrate the function of what you found, and also with the clinician to understand which one is the right treatment. So this again shows you this collaboration. The patient can be a child, but can be also an adult, because now we know that many immunodeficiency will manifest only when you are older, when not, only very severe immunodeficiency manifests when you are a child. And also we'll come back to that. The clinician, the lab, and the genetics. And there is a very, very important point that there are some diseases, the most severe one, the most severe immunodeficiency, which we can diagnose in reality very early, just with the genetics, and we'll come back to that. And it's very important, this collaboration between the genetic group and the laboratory that does flow cytometry functional analysis, because you really understand the mechanism, what is at the base of the disease. I have this slide just because I've also studied gynecology, but in reality to make you understand why often primary immunodeficiency, also the severe one, don't manifest when you are just a very, very little baby. Because in the beginning of our life, the antibodies that are from our mothers that are transported through the placenta during pregnancy, and those that are given with breast milk after you're born, those antibodies protect you. So in reality, if you have a primary immunodeficiency, I mean, you don't see it really when you are like 1, 2, 3 months old, unless it's a very severe one, because your mother is giving a treatment with her own antibodies. You know, it's just a passive help. Then this one, this slide, remember, so you want to remind you that both, you know, we are talking now, I will talk especially about defect of adaptive immunity. And this defect of adaptive immunity all come because there is one of these two lines, the T cells or the B cell, that is not working. And all B cells and T cells are generated in the bone marrow from a common lymphoid precursor that will generate directly immature B cells that will go to the periphery, or this common lymphoid protogenitor will be transferred to the thymus, and here will give rise to the mature T cells. And the point is that most simple, let's say, diagnosis for somebody who is studying immunodeficiency is, of course, SCID. So it's normally the most frequent causes of SCID are defect or other mutation della common gamma chain gene or of JAK3 genes. These are severe diseases where the defect is so heavy that you don't have T cells and you don't have NK cells, or even you don't have even B cells. And of course, there are a lot of symptoms, but these symptoms may start too late. The real problem, because they start, when the antibodies of your mother are not functioning anymore. And then the diagnosis is made maybe when you are 6-7 months old, and that's a problem, because the very important thing in these severe cases is to make the diagnosis very early, because the only treatment that we have to cure the fact that you have no B cells, no T cells, no NK cells, you have to receive either a bone marrow transplantation or a thymus transplantation. I will show you that. But, with flow cytometry, what you can do, you can see all the populations in your blood. It's a very simple, in reality, analysis. It's very simple. You can see here, there is a machine where you see the cells, you see the size of the cells, and even just from the size, you can recognize the lymphocyte, the monocyte, and the neutrophils. And then you can see, do I have T cells? And look here what happened. This is a case we diagnosed in the lab. You can see here that T cells, which are the most prominent population among lymphocytes, you have none. And then if a child has no T cells, and then it will have no CD4, no CD8. In this case was a case where there were no NK cells, but the patient had B cells because it was a common gamma chain deficiency. This is a very simple diagnosis, but it's a diagnosis you don't want to do with this system, because what you really want to do is to make the diagnosis on the cord blood and detect on the dry spot that you have from the cord blood, and there you can see if you are producing new T cell. The test is called TRAC, and it's a very simple test that you can do at birth. Maybe Dr. Condino-Neto will talk more about this, but then it's very important because it means this child cannot do T cells. So if he cannot do T cells, either his common lymphoid progenitor is not working or his thymus is not working. You also have to understand this, because if it's a common lymphoid progenitor that doesn't work, you have to do a bone marrow transplantation, and you have to do this bone marrow transplantation early, before the child is 7 months old, before the child is 5 months old, because then it all works and they will be cured. If you do it when the child is sick, then it's much more difficult, and there will be cases where it will not work. If instead the defect is of the thymus, you have, of course, to make a thymus transplantation, but that can be diagnosed. Now, what about what we really do, what happens all the times in flow cytometry? So I am trying to show you how easy it is in reality, knowing the markers and knowing the method, to see that the peripheral development of the cells works. Because of course I had shown you, you have the common lymphoid progenitor, this guy will go either to the periphery or is going to go to the thymus, but then it's not, the cell is not staying like that. You know that when we are children, we will go to school, we will have a job, then we have a job. For example, myself, I am a doctor, but also I'm a mother. I also cook, I also clean the house. So a cell can do many things, as we can do many things. As B cells can have different specialization. So the same cells that comes from the bone marrow, which, I don't know, do you see my pointer? Probably yes. So there can be a transitional cells, that is this one here, this tip here, that will differentiate in the periphery into mature naive cells, which these are cells which I have not used still. These are the plasmablasts, the cells that are making antibodies, and these are my memory cells. And there are two types of memory cells in the periphery. These are the naive cells. It's a different view of what you see here, but I want to show you the fact that the cell that came from the bone marrow will differentiate in many different cell types, and it's the same for T cells. So you have the CD8 CD3 positive cells, which include alpha beta producing T cells, gamma delta producing T cells, and then the alpha beta would be either CD4 or CD8, and the CD4 and CD8 will have different jobs. So will be naive, will be central memory, effector memory, terminally differentiated. Unfortunately, what happens when you have an immune deficiency, any of these steps can go wrong, but you have to know which step is going wrong, and you can learn this from the phenotype, even when you do have the cells, but these cells don't work. For example, I make you just an example. Now, let's say these are my CD4 T cells, no? And I have the naive cells, the central memory, then the effector memory, and these are the one I don't use anymore. And this is a normal person. So you see here the lymphocytes, the naive cells, the cells I have not used, and these are my memory cells. Now I show you here, this is a lymphoid follicle in the spleen of an adult, a normal person. And you see that these cells, of course, don't work in the blood. They will go in some place, no? Will go in some place, and they go, for example, in these primary follicles, and they will be the T cells, these green ones. They will go here in the primary follicle, and they will collaborate with the white cells that are the B cells, and the very, very white cells, those are cells that are making antibodies, the plasmablast I showed you before. And so there is all a collaboration that is necessary, for example, to do memory B cells. And memory B cells of two types. So these are the IgM memory cells that are less differentiated, and these are the switch memory cells, the one that make antibodies that, for example, many people with common variable immunodeficiencies don't have. No, these are the cells that make antibodies. Now, look what happens in a primary immunodeficiency, which we are studying right now, where you can see that you have a lot of naive cells. These are the naive cells. I can do the diagnosis just like this and then understand in collaboration with the genetic group what is the gene that is not working. And you see that there is a population here that is missing completely the central memory and the effector memory. The cells is naive and cannot change anymore. Now, what happens here? I have my lymphoid follicle. My T cells don't work. And in the lymphoid follicle, TB collaboration is indispensable to make antibodies and to make memory cells. And what happens in the patient that does not have this collaboration, what you can see is that some of the less differentiated memory cells, but completely misses this population. And this is patient with the disease, which is called primary common variable immunodeficiency, where we have demonstrated that the TB collaboration is impossible. So this person cannot make antibodies and has to be treated. But now we know which one is the defect. We can find the gene that is deficient, and maybe we can find a better therapy. Oh, sorry, I went too fast. Okay. And now I'll show you, I work in a children's hospital. So we studied especially memory B cells. And you can see here, the memory B cells can be distinguished because they express this marker, which is called CD27. Look here, you see in the last two slots on the right, you can see how memory B cells look like in an adult. Each one of us in adults, memory B cells are about 50 to 60% of our B cells. So there are really many. And there are the two types, CD27 dull and bright. And look what happened in children. Children, you see, they have only this very early population, which we call CD27 dull. This is a population that is sort of innate, that doesn't require the collaboration with T cell to be generated. And how did we learn that? Because this, you see, before transplantation, 6 to 7 months old, this is a very typical case. So we made the diagnosis in the lab in two patients, patient 1 and patient 2. These patients had a defect of common gamma chain. So we had made the diagnosis because they had no T cells. They came to us when they were 6 to 7 months old. So when they had finished the antibodies from the mother, and they had now lots of infections. And you can see that they have some memory B cells, but they really lack the more differentiated population. The patient 3 was also a patient without T cells, but he had a JAK3 deficiency, so he had slightly more memory cells, but lacked all the most differentiated population, because in this case also, he couldn't make any collaboration between T and B cells because he didn't have the T cells. And another situation where you cannot have a T B cell collaboration is the deficiency of CD40 ligand. CD40 ligand is a molecule that is indispensable in the follicle, the one I showed you before, you know, where T B cell collaborate. These guys were 1 year old, 8 years old, 33 years old, and you see they had the CD40 ligand deficiency, and you can see that they had only CD27 dull cells, and they miss completely the other population here because they cannot make germinal centers. And now, flow cytometry in this case can help you also to make the diagnosis, because when you have the suspicion that this person cannot make the CD40 ligand, by flow cytometry you can do a functional test where you take the peripheral blood of this person, you stimulate the cells with PMA ionomycin for overnight, and then you see that the normal person will express the CD40 ligand, and if you have a defect of these genes, you cannot express the molecule, but then you know what's wrong. And that's very, very important for the further clinical follow-up of the patient. And here, this is what we found studying our patients. This is the germinal center, what I showed you before. That is very important because it's like when B cell work. I am a medical doctor, you know, many of you are medical doctors, you work in hospital, you work in your praxis, but you are able to make a diagnosis. So B cells also should be able to do their job, that is to be in the germinal center and to make antibodies and T cells to become memory cells. And if you don't do it, then everything is blocked and you don't have the defense in the periphery. And this is also to show you again what we did with transplantation and with a bone marrow transplantation. This is the boy with the common gamma chain. No, sorry, this is JAK3 deficiency. This were his B cells before transplantation. And you see that after it's been transplanted, now he has T cells. These T cells work very well. And then his B cells become dull and bright for TD27. And of course, the difference here is that these cells have been modified to be very specific for the antigen. You can help with the genetic to see whether everything works with the measurement of somatic mutations. And this is another thing that we did I'm showing you how much you can do with flow cytometry. And this is what we did many years ago in reality, because we were studying this disease I mentioned before. Common variable immunodeficiency is a disease where, you know, where the patients are not able to make antibodies. And you treat all these patients by giving antibodies from donors. It's about the treatment that we learn from our mothers. You know, you remember I told you before, the mother can give the does give all the time antibodies to the baby because the baby is not able still to make his own antibodies. And people with common variable immunodeficiency receive antibodies from donors. So they are protected somehow, but they are not protected completely well because some of them are still very sick and they develop lung problem, lung damage. And what we could show by flow cytometry is that among the two types of memory cells that you normally have in the blood, people who have still a lot of infection, notwithstanding the treatment with immunoglobulin, lack a population that is this one here that is called the IgM memory cells. And why these were so important, you always have to go. When you do then the functional study, you do the diagnosis, you say these people have this defect, but what else? Why do I have lung infection? And then we look at mucosal side, in this case where mucosal biopsies of the gut, and you can see here in red, in green, you know, in red you see the structure of the gut essentially, and in green you see antibodies of IgA type, and we found out that these IgM memory cells were necessary to go to the gut and to differentiate in plasma cells there. So you know now, what do I have to do? I have to protect the people with different treatments because the real problem is at mucosal side. And this is another study which we did also with the patient with common variable immunodeficiency. Again, you know, this with the COVID pandemic, there was also the possibility to see the response of these people to an antigen which nobody had seen before. So we had the patient who were treated, the immunoglobulin they received didn't have the antibodies against this antigen, and the controls also had never seen the antigen before. So you can really check, can I measure if this patient reacts can I simulate their B cells? And what we found out is that if you only look at serum immunoglobulin, what you see is that you think that more than 60% of the patients are responding to the vaccination, all the patients were treated with the mRNA vaccines. But if you really look at memory cells, you find out that in reality, only 30% of the patients are responding, because the memory cells are these ones. You see now this, with the COVID, we had the opportunity to use cytometry for things we didn't use before, because you can see here it's a fluorescent spike we are using, so you can see if the B cells bind to spike. You see these S+ cells are cells that really recognize the spike. So the vaccine really worked very well in this group 1 patient. It's like a control, like a normal person. But then you see that in the other patients, there were no, although there were antibodies in the serum, there were no cells that were specific for spike, and even less cells that were specific for the receptor binding domain of spike, which is the really important part for the ability to neutralize the virus. And then we develop all these hypotheses of the 4 groups of patients, but the real important thing is that this correlates with clinical disease. So you can have a test that you do by flow cytometry, you try to understand what the problem is, and then this correlates with clinical disease. Why this is important? Because if you make this test in the beginning, when you see the patient for the first time, the effect is already there, and you know how the disease will develop. And so you can choose the right treatment in the beginning before you have the complications, because I think that's a very important thing. We have to prevent the complications. And we use again, because this one is even not published as yet, we used the flow cytometry to study what the immune defect is of people who have been splenectomized. You know that people who are splenectomized are included among the people with altered immune deficiency, but nobody really knows exactly what's wrong with them, because you can be splenectomized because you have a car accident or you have to have a surgery. So what's wrong with these people? We again tested the response to COVID vaccines, and again you can see that both adults and children with or without spleen have a lot of antibodies, against the SARS-CoV-2. But then if you look at memory cells, you see again that these are the controls, and all the other colorful columns are the patients who have been splenectomized, or have even some of them, the yellow ones, are born without spleen. And what you see is that they cannot make memory cells that are specific for the vaccine, although we have immunized them in the arm, although these guys had no immunological defect before losing the spleen. And what we found is that if you look in the spleen of everybody, these are the spleens of organ donors, what you can see is that when you are these are spleen collected before 2019, and this is after 2021. And you can see that in the spleen that are collected after 2021, there are spike-specific B cells that went to the spleen. So you can really see that the problem is that you are immunized in your arm, your cells will be produced in the local germinal centers, they will go around in your blood, from your blood they will go to the spleen, where it's a sort of place where memory B cells are stored, and they will go back again in the circulation if you have the spleen. If you don't have the spleen, this is not working. So by flow cytometry, we found out this, and why this is important. It's important because we have learned where memory B cells are stored. We have learned that they go from there, they leave again, they recirculate, they go back. So it's very important for the splenic patient, because in this case, what you have to do is to re-immunize, give booster doses to these people, and then you need really tailored vaccination protocols. And so what we really want to know by flow cytometry is to make an early diagnosis, to find the right treatment, and to follow up the patient. And then we can do much more sophisticated studies. For example, we are doing also that with RNA-seq, single-cell RNA-seq, where you really find what is, you identify new population, you find what is every cell doing. And, you know, as I told you before, each cell does different jobs, although it's the same cell can do different jobs. And we have to understand which one is the job and what's wrong with that part. And we found out now it's very complicated. I'm not showing to you that you can do a lot of things. For example, finding new markers that we did in this case. And we found that in the blood, there are two populations of cells that are produced when you are activated. So when you see a new antigen, and these two populations are very important because one of these, the activated memory B cell, the one in red, is increased in a lot of primary immunodeficiency. We just found out that, and we are going to study that further because these cells have a very good site. They can go to mucosal site and protect you, but they can also go to places of inflammation and damage you a lot. So essentially, what we do by flow cytometry is we study the longitudinal variation in each individual. I've shown you before that you can study how the cells change when you are born and when you are 1 year old and during your life. And now we're studying also what happens with aging. And there will be a lot of individual variation, but there will be also cases where you can really identify the mechanism that is blocked. And that's very important because you can make the genetic diagnosis and then follow up the patient. And these are the people working in my lab and all the people that collaborate with us. And thank you for your attention.
Yeah, we thank you, Dr. Carsetti, for this very enlightening presentation. And now I am turning to you, Dr. Condino Neto. Would you have any comment?
Oh, yes. Congratulations, Rita, for this excellent presentation. It was very comprehensive, and you have shown the many applications of flow cytometer in diagnosis of primary immunodeficiencies. So let's discuss a little bit about children and a little bit about adults.
Yes.
In children, currently we have in many countries the newborn screening.
Yeah.
So what we do is we use the dried blood spots, and in there we assay the number of copies of the T-cell receptor excision circles, the tracks, and also the kappa receptor excision circles relating to the B cells. So depending on the technique and in the lab standards, we will have a minimum number of copies that will serve as a screening for a probable immunodeficiency, either a gamma globulinemia or a T-cell deficiency or a SCID, which is a severe combined immunodeficiency. You know, it has been becoming very popular to talk about tracks and cracks, but as we have just watched on and learned from Rita's presentation, the mandatory exam is the flow cytometer. We must make an analysis and a real count of the B cells and T cells in order to confirm that diagnosis. And further than that, it is necessary to pay attention on the number of naive cells.
Exactly.
So children is about naive cells. The immune system is still to be developed. In older people, we look at the memory cells, but children is naive cells. So, Rita, would you like to comment on more detail about this?
Yes. So in Italy, there are some of these centers that are doing the dry spot analysis, but it's not effective at the national level. And that's something we are fighting for, because it should be done at the national level, exactly because the real problem is that if you do the therapy, the transplantation, you have to do it as early as possible before the child has the infection. So using these famous 3 months when your mama is helping you with their own antibodies. So why do you need also the cytometry? Is that it's a confirmation thing. So you do the crack and the track, as Dr. Antonio Condino has said, and then you check whether taking the small amount of blood of the baby, if you can find T cells, and what he has said, if these cells are naive. Why is that? Because when the child does not have his own T cells, you can find some cells from the mother in the blood of the child. And we did, we found those cells in those kids I'd shown you before, and they were all memory, because the cells can migrate very well and go to the child. Those are memory cells. The child can't have memory, can't remember anything, it's just born. So then you make the diagnosis by checking that those are naive cells. There are certain cases, for example, making why this is also important. There are some type of cases, for example, Down syndrome. In Down syndrome, you may have too few cracks and too few tracks in the beginning. But in reality, then you see that the child has enough T cells. So you really can discriminate real disease from cases where you have doubts. So it's very important, this collaboration between the geneticist and the diagnostic immunology lab, because we work in team. Otherwise, nobody of us is able to do it by yourself, I think. At least.
Yes, so these are very important points. So as long as the pediatrician and the neonatologist will focus on the naive T cells in order to make a diagnosis, we also have to consider other forms of immune defects that are not necessarily skin, but they are linked to other genetic conditions, as just Rita said. So the Down syndrome. The Down syndrome in early life, they can show up with some immunodeficiency. And for example, DiGeorge syndrome. Those patients will present with thymic defects, and they will have including a variable intensity of the immunodeficiency. So for those intermediate cases, Rita, would you like to comment more in more detail the flow cytometer analysis of Down syndrome and DiGeorge patients, for example?
What we do is as an extended panel on T and B cells, essentially. And then if you look at the all different populations, which you can do by flow cytometry, and it's really simple, so it can be done, then you don't, of course, I mean, most of the time, the people who don't study immunodeficiency normally do this, how's called, the subpopulation, the B cells, the T cells, CD4 and CD8. That is useful if you want to make a diagnosis of a very severe disease. But as we were discussing now, where you have a more fine defect, let's say, you will not be able to diagnose like that, because you will have to see whether all these cells are functioning. And we said before, cells function and assume different phenotypes because we are doing different things. So as we have the lab coat, if we are in the lab, and now I don't have a lab coat because I am at home. So it's the same thing for B cells, for T cells. So when we use the right markers, we can understand which population is missing. For example, Down syndrome kids, we did a study on that. They may have a reduced number of B cells that are switched and they are of the memory type. And so those are things you learn to know, and we even understood the problem. The problem is that the germinal center function in Down syndrome doesn't work very well because they have a deficit of certain microRNA that are indispensable in the germinal center function. That's very important, again, because if you understand what is the problem, what you can expect, then you can follow up the patient and do the right therapy.
Very nice, Rita. And still in children, there are cases of combined immunodeficiencies, but they are not necessarily SCID. Yeah. So would you like to comment on this on more detail?
I mean, these are defects that we are learning to diagnose always more. And the real problem that we have in these cases is what is the treatment. I find that that's a real difficult thing to decide because, of course, you know, the best treatment, I mean, like the most curative treatment, to think about SCID, it's bone marrow transplantation. But more marrow transplantation has risks. So it's very difficult to decide, even though we have now a lot of adult immunodeficiencies where we found a combined immunodeficiency in reality. And these are people which are treated, who are treated with immunoglobulins, for example, and it will not solve the problem, but now they're adults. And it's a very, how do you say, it's very, very difficult situation because we have to develop better treatment for these people, and then we can find a better treatment because now we have a lot of molecular drugs that you can use if we know the genetics.
So in other words, it is apparently easier to decide on the treatment of a SCID baby that we have to go on the bone marrow transplant or even gene therapy when available. Yeah. But on the combined immunodeficient babies, there is no clear recipe.
Yeah.
So perhaps we have to follow those patients, use prophylactic and antibiotics and immunoglobulin replacement therapy. And in this case, the flow cytometer will be of a special value that we can correlate the cell counts and function in parallel with the clinical presentation and decide the best to do with the patient, case by case. So in this case, the flow cytometer is really crucial for the follow-up. There are another group of patients.
I wanted just to say that it's very important to do the cytometry because it's very fast and it's a very precise type of thing that you can do. I think it's...
Yeah, and there is another very frequent presentation for us immunologists to make consultations are those hospitals where they receive children with inborn cardiac malformations, and the children have to go on heart surgery, and in order to do that, the thymus will be affected. And do you remember of any special case on this, Rita, that you use the flow cytometer to follow up the patient and help the cardiologists and the pediatricians to make decisions on those patients?
I have to say that we didn't do this, so I tell you really what our experience is. One experience which we have with the cardiology is is the study of Ive-Mark syndromes. Ive-Mark syndrome is a complex disease where people have a transposition of the vessels because there is a defect during the embryogenesis whereby a part of the body has to rotate during embryogenesis, and there is a wrong rotation of the endoderm, so the vases, the vessels are put in the wrong way as compared to where the heart is. And this is a disease where children have to be operated. The thymus goes away, of course, because it's in front of the heart. So you have to remove it because you can operate. And then what happens is that some of these kids have no spleen. That's because when this rotation, it depends on what it affects. So some of these kids have no spleen. So what happens is that these kids before were, many of them, the one without spleen, were dying of infection. And then we started a collaboration with them, trying to study the difference between the one with spleen and the one without spleen. And now, since about 10 years, we are following up this treatment. Nobody died anymore of infections. So all the kids underwent surgery. We understood what the problem was. Then the kids have really to be careful about the antibiotics, about lots of vaccinations, more vaccination than other kids. And then we didn't lose anybody because of infection. Before, in all world, there was 50% children dying because of infection, which is stupid.
Yes, I have asked you about those patients with cardiac malformations. In the state where I live in Brazil, state of São Paulo, this state has a population of 45 million inhabitants. And in the state, we have 6 major hospitals dedicated to cardiac malformation. So it's a product of São Paulo medical environment. Cardiology here is taken very seriously, and our state will attend for children for the entire Brazil and other Latin American countries. So very frequently, we immunologists are requested to follow up those kids. And it is very important to use the information of the flow cytometer along with the antibody tests and specific antibody tests, total antibodies, and give the proper immunological support, because it makes no sense to do all those complexity of surgeries and lose the patient on sepsis because the immunology part was neglected. So here in São Paulo, it's a place that we can develop a research about that, and flow cytometer should be very useful. Okay, so let's talk a little bit about adults. Rita, we have talked a lot about children. I'm a pediatrician. Now let's talk about adults. So CVID. CVID is a very important group of diseases for the adolescents and adults. And we know there are several types of CVID, molecular defects, and they will show up clinically with differences in terms of susceptibility of infection, autoimmunity, susceptibility to cancer, and some patients will go on those functional problems in losing memory cells. So would you like to discuss a little bit more in detail the situation in adults, Rita?
So common variable immunodeficiency is frequent in reality. It's one of the immunodeficiency that occurs frequently. And the treatment for people with common variable immunodeficiency is always the same. So you give immunoglobulins because these patients are not able to maintain a normal level of immunoglobulins. The immunoglobulins are from the donors. So each one of us, for example, can be a donor of immunoglobulins. And then what it means is that you are protected from all the disease that the donor has experienced. And that has helped a lot because, people before had a lot of viral infections and a lot of different things, which now they don't have anymore. And the treatment can be even performed at home. Before, you always had to go to the hospital to have the intravenous immunoglobulin treatment, but now you can give it even at home subcutaneously. So it's a disease which can be controlled. The problem with common variable immunodeficiency is that it's a sort of a mixed ball of genetic defects. You don't really know what these people have. You know that they cannot make antibodies, but the process of making antibodies is very complex because you have to have T B cells collaborating. The B cells has to see the antigen, the T cells has to see the antigen. You have to have the antigen present. It's a really complicated thing. So you really don't know what's wrong. And then, as you don't know what's wrong, there will be people with different diseases, different clinical diseases, because it depends on what's not working. And so some of these patients will do very well with the antibodies given by the donors. Some patients will not do completely well. And then our now idea is that we really have to understand what's wrong with these patients who are not doing very well. Of course, now we're doing the genetics of all patients with common variable immunodeficiency, because you may have a defect where you have all the cells, everything is working, but then the cells that make the antibodies, really the terminal differentiated plasma cells, are not working. Then your immune system is a sort of okay. The only thing you miss is that antibody. I give it to you, then you're fine. But if your problem is a different one, so like the B cells or the T cell cannot be activated, you may have other problems, for example, at mucosal site. And we found this in many patients with common variable immunodeficiency. And there, really, we should develop better treatment for giving antibodies even at mucosal sites. Or you have an exaggerated inflammation. And now we have to understand why you have that inflammation. How do I cure that inflammation? Sometimes the lung problems is due to autoimmunity or too much inflammation. So in these cases, we are trying to understand how to cure that better. That's why we are trying to classify the patient in several groups, because each one of them needs a specific treatment. We have a lot of...
Rita, I wanted to jump in, especially because you're speaking about CVID, and we have a question from a patient representative from Sweden. If I understand correct, patients with CVID without IgM memory cells have a more severe disease. Can the number of IgM memory cells change over time? And is it important to control the patient's number of memory cells regularly?
Normally each patient, each CVID patient is very characteristic. So in the sense that if you analyze the patient today or in 3 months, the phenotype is going to be the same, so that the number of memory cells will be changing a little bit, but not changing in a dramatic way. So, but it's important to know to which group you belong, because you may need a different treatment, though you may expect a different evolution of the disease. So that's important for the doctor to know.
And coming back to that, if I might jump in,
yes.
So is there, is there any variability? The variance. If you perform the test several times, are you most likely to find the same results? And in other words, it's a question that somebody asked. Do you think it is important to have a standardized flow cytometry method for the best accurate diagnosis?
I mean, to have the standardized flow cytometry method is indispensable. It's indispensable because you can do a lot of wrong things with flow cytometry, and if you have a defined setting and defined type of antibodies you used, it's very stable. And let's see, if you take a normal person, for example, children, I have a lot of experience with children. So the B cell or the T cell phenotype may change with, for example, infections, severe infection. If you have a chronic infection, if you have malaria, it's really, your phenotype changes a lot. Or if you have even a recent severe infection, measles, your phenotype changes. But normally, I think if you in several immunodeficiency, if you do the test today, if you do it in 6 months, the phenotype is going to be more or less stable. So it's so dramatic, the difference that you will be between the controls and the patient, that this is not going to be affected from doing it today or in 1 week or in 1 week or in 1 month. But you have to have a standardized system, because otherwise you make a lot of mistakes.
Thank you.
You have to know the age, sorry, of the patient. Sorry, excuse me.
No, I was thanking you, and you said that you could potentially, I mean, if someone is interested, you could share your
anytime.
Standardized protocols. There are 2 questions regarding a specific technique using the Cytognose BD PID tube, just to diagnose and screen patients with PID. It's quite technical, but maybe if you just give a few words on this.
So this tube is a new product, and we've been using it. And it's what is interesting is that you can see all the B cells, the T cells, and even the gamma delta cells, and a lot of other cells, the monocytes, all at once. So you do one test, and in a few hours you have a picture of your immune system. So it's a good system to be used, and we are even using to see minor defects now. But then, of course, you can do even more sophisticated, studies after that.
And if I may, one quick question from the chat: can flow studies be used for functional studies of immune cell functions?
Yeah. So what we use several functional studies. So I have shown you, in my presentation, it was a bit faster, that you can see if you have a CD40 ligand defect. Now, CD40 ligand is a molecule that is indispensable for the collaboration between T and B cells, and is not expressed by cells in the circulating blood, which, of course, you have to consider that we have to do all our tests on the blood. So then you can induce these markers, by stimulating the cells. And if you have a suspicion, you do this test in vitro, it's overnight test, and you can see if the person is in principle able to express the CD40 ligand. But there are many other functional tests that you can do to measure the T cells function, by stimulate them polyclonally or with a specific antigen. And also there is a very important test that we do is about NK function, because there is this disease which is called familial lymphohistiocytosis. That is a severe disease that can manifest really in the newborn already, and it's a disease where your NK cells don't work. And why the NK cells don't work, you don't really know, but what happens is the NK cells kill cells that are infected by viruses. So then the child has a virus and they develop a very severe disease, which is devastating. And then you have to know whether it's the NK cells that doesn't work, and you can do this by flow cytometry.
Thank you very much.
Test this.
Sorry. Thank you very much. No worries. A pleasure to listen to you. But I think for the sake of time, because we're running, running a bit behind the time, I hand it over to Martine.
Thank you, Nizar. And indeed, thank you to both of you. Before we come to the end of this hard talk, I want to thank both of you for discussing the role of flow cytometry screening for earlier PID diagnosis, to Dr. Condino Neto for being such a good challenger with many questions, and to Dr. Carsetti for your very interesting talk and for all the answers you have provided. We will have shortly a feedback form on the screen, and it's very useful for us to know your feedback and to hear your comments to continue to improve our concept. Thanks again to all of you for attending the second edition of IPOPI Hard Talks. In a few days, you will be able to watch it on IPOPI YouTube channel. Don't hesitate to share it as much as you can. And many thanks again to all of you and to our sponsor, BD, for making this possible. Thank you, and see you.
Thank you.
Bye. Thank you.
Bye-bye.